the topic gaining a wider outlook on diabetes management with second generation basal insulin. Dr. Luthra is heading our Fortis CDOC Center at FMRI Gurgaon. Over to you, sir.
Thanks, Amrita. So at last, at the fag end of the day one, we finally have a lecture on insulin. So the triad of glycemic control and hyperglycemia is well known, and but the diabetes management algorithm and concepts are evolving rapidly. So this does not suffice, but we need a good quality of life, we need improved cardiovascular and renal outcomes, we don't want hypoglycemia and weight gain, and we want to minimize glycemic variability on a day-to-day basis. So the triad of fasting, post-meal and A1C is now a hexagon where we have equal importance to the measures of glucose and also on emphasis on lack of side effects with drugs like hypoglycemia and weight gain, and improved quality of life and with improved cardiac and renal outcomes, maybe a better longevity. And of course, on a day-to-day basis, glycemic variability is also to be avoided. Now, how do we assess glycemic variability? If we tell people to monitor their glucose regularly, they don't do a good job. As Professor Mishra has pointed out, most people come out to your clinic every 3 months with a few fasting readings and one HbA1c of the previous visit and the current one. But now we have continuous glucose monitoring systems which can give us an ambulatory glucose profile, and we see the peaks and troughs, we see the mean, medians, we see the target values, we see where the spikes are coming and where the troughs are coming. And this is a sample report from a CGM. So a very recent concept in glycemic assessment is the time in range, which is the portion of the 24-hour period in which the patient is in a range that is acceptable. And in most patients, this acceptable target range is 70 to 180. So if a person remains maybe 70% of the time in this range, we say that this is good glycemic control. So we have a new metric of assessing glycemic control. So these new metrics now can tell us exactly how the patient is doing, and the patient doesn't need to monitor or prick his fingers with a glucometer and glucose sticks usage every time. So you see the right side, so target range 70 to 180. If it is above 180, it is high, obviously. Above 250 is very high. And below 70 is not desirable, it's low. And 54 is a little dicey, so very low. So the advances, technologies, treatment, they give us different TIRs for different diabetes populations. But needless to say, for most patients, target range 70% of the 24-hour cycle between 70 to 180 is acceptable. Of course, in older people and people with multiple comorbidities where you want to go a little easy, you can accept a 50% TIR. And of course, in pregnancy, gestational diabetes, we want very tight control, and there the target range is 63 to 140. So, beyond A1C, glycemic variability, time in range are the key important glycemic metrics to support effective management, and this is now the accepted international glycemia guidelines, because suboptimal time in range has been now demonstrated to impact negatively the lives of diabetes by increasing the risk of microvascular complications and maybe to some extent cardiovascular mortality. So how do we go about setting the time in range? Probably in all of us who manage diabetes, so we know that when a combination of oral drugs fails to produce the desired values, and it is mainly the fasting blood glucose, which is the patient wakes up with a value which is not acceptable, then we start with the basal insulin. And basal insulin is a good idea because it fixes the fasting blood glucose first. Not only that, when you use a basal insulin at night generally, you lower the entire postprandial glycemic spikes and you achieve a decent control. Of course, you have the option of additional therapies later on. So the currently available basal insulins to fix the fasting first, of course historically NPH still works wonders. The standard old glargine, then we have etimine, we have deglutec, and we have glargine U300, which is a 3 times more concentrated form than the previous one. So the relatively new insulins are the deglutec U200, glargine U300, and of course in about a year's time we would have a revolution which every diabetologist would love, and it would be a game changer for diabetologists and maybe life changer for patients. A once a week basal insulin called icodec. So now U300 is what we are going to just talk about. So if we compare glargine U300, the new glargine, versus the first generation basal insulin and see the comparative analysis of the CGM profile and the glycemic variability. So what you see in the blue line is the glycemic pattern with the old U100 glargine, and the green line is what you see with the U300 glargine, and you notice that the mean amplitude of glycemic excursions is less, the overall glycemic variability is less, and the day profile is far smoother. Another interesting fact about glargine U300 is that it allows flexibility in injection timing to deal with the situational variability in day-to-day life. So if no matter how much we tell people to stick to their time of insulin after dinner and take it the same time every day, but because of patients' commitments, either social or professional, people end up fluctuating that time. So most days would take between 9 or 10, some days there is a festival, some days there is a party, somebody is traveling. So, but with glargine 300, this particular preparation compared to the conventional formulation allows a 3 plus or a 3 minus hour flexibility in dosing. So to deal with the day-to-day variation in the timing of the injection because of any reason. If we compare glargine U300 to the first generation basal insulin of U100, there is lesser chance of nocturnal glycemic variability and also nocturnal hypoglycemia. So the key metrics to support effective diabetes management, besides fasting, post-meal, HbA1c, glycemic variability and TIR, and we know that suboptimal TIR can lead to microvascular complications. So glargine 300 in a nutshell has a smoother kinetic and dynamic profile. Therefore, it does allow for injection time flexibility, less glycemic variability, non-inferior to deglutec 100 in people with type 1 diabetes, and no difference in hypoglycemia or other safety parameters compared to deglutec 100 or 200. So just to summarize what I have just spoken, glycemic variability and suboptimal TIR are the new glycemic metrics which significantly impact the lives of patients with diabetes. Glargine U300 allows a dose flexibility of a give and take 3 hours in timing of injection to deal with the daily life situational variability. Numerous trials using continuous glucose monitoring systems, timing range profiles have demonstrated that Glargine U300 provides effective and sustained glycemic control with lower glycemic variability, and the use is associated with lower incidence of overall and particularly nocturnal hypoglycemia. Thank you for your attention.